I'd like to thank the organizers for giving me this opportunity to speak on this subject. So I actually looked up the definition, exact definition of value addition. And when you go through the literature as far as systemic therapies of sarcomas is concerned, you really have to hunt for the value addition. My job has been made easier by the previous speaker because many of the studies have been covered. Fortunately, my slides do not overlap, so I'm thankful for that. So what are in this systemic therapy, what is the challenges that we face as far as ascertaining the value addition of systemic therapies in these various tumors? The first is the rarity of the tumors, and one of the studies that was shown, that was from Hensley et al. From Memorial Sloan Kettering Cancer Center. It actually highlights the problem that we face with these sarcomas. That they had an international study ongoing. They had to accrue 216 patients, but they could only accrue 38 patients. And that was still presented at the ASCO 2018. So this is one of the problems. The second is the histopathologic heterogeneity of sarcomas. Dr. Reiki has clearly shown you the heterogeneity, and you need a very good pathologist to really distinguish the various subtypes of these sarcomas, because as has been shown by Dr. Reiki as well as the Dr. Saket, that it's very important. Your approach for systemic therapies is going to differ based on this. And the paucity of systemic therapeutic options. Nothing has really changed in the last decade as far as the chemotherapy options are concerned. Of course, and as far as the targeted agents are concerned, we've made very little progress. And there is a dearth of robust phase 3 data. So I'm going to, as you know, that amongst the gynecologic sarcomas, the uterine sarcomas constitute almost 83%, and almost 30 to 40% of these are leiomyosarcomas. And that is where you have most of the data. So I'm not going to touch in this short time about the sarcomas arising from the ovary or the vagina, but I'm going to touch mainly on the uterine sarcomas, and that too on the leiomyosarcomas and the endometrial stromal sarcomas. You can see that the first question comes about adjuvant chemotherapy in early stage leiomyosarcomas who have undergone optimal surgical treatment. Now, first of all, it was the GOG phase 3 study in 156 all uterine sarcomas. There was no improvement in the progression-free and overall survival, though there was a non-significant higher response rate. Then, of course, comes the gemcitabine, which is a fixed dose rate. You know that it's 900 milligram per meter square over 90 minutes, plus docetaxel. A retrospective cohort study of 111 patients in stage 1 leiomyosarcomas, uterine. There was no benefit. Then, of course, you have the gemcitabine docetaxel into 4 and doxorubicin into 4. This was the international collaborative study, and again it showed a futility accrual, and that's why the study was closed. But there was data coming out of those 38 patients, and again when they compared with patients who did not receive the adjuvant therapy versus those who received, again it showed no superior outcome with chemotherapy. So as far as adjuvant chemotherapy is concerned, I think the matter is almost laid to rest that adjuvant therapy, I'm only talking of chemotherapy, is not advocated for stage 1 and stage 2. And of course, if it is stage 3 and stage 4 completely resected, then they need adjuvant chemotherapy. And the options, as you know, that it's already been stated that there was a study of gemcitabine docetaxel versus gemcitabine, and the combination was superior. And as far as doxorubicin and gemcitabine docetaxel are concerned, you could choose either. So both are approved as first-line therapies. Now, this is some of the data that you look at the 5-year disease-specific survival by stage. This is the SEER data from 1988 to 2003. And you can see that even stage 1 and stage 2, still about 30% do relapse. And I think the adjuvant studies are not, we don't have the numbers to really make a decision. So there are some people who still offer adjuvant chemotherapy in these stages. Now, if you look at the adjuvant, this is the meta-analysis. So this is an important meta-analysis published in 2020 looking at 9 trials, and you can see that if you compare the chemotherapy versus no chemotherapy, as far as distant recurrence, loco-regional recurrence, all overall recurrence is concerned, there was absolutely no benefit. So even though you don't have randomized study, this is a collation of all the meta-analysis of 9 trials, and there's one more meta-analysis which has also shown that there is no benefit for adjuvant therapy. But it's very interesting that some of these meta-analyses have actually shown that there is an increasing use of chemotherapy amongst physicians in leiomyosarcomas. So now, of course, you come to the systemic therapies in metastatic setting, and again the leiomyosarcomas, the uterine ones, and you can see that these are the 3 studies, the GOG 87L, and you can see the response rate is around 35.8%. You do get certain CR rates, and it's very interesting that the leiomyosarcomas that originate in the uterus, they do much better on chemotherapy than the extrauterine leiomyosarcomas. I have had a couple of patients who have been long-term survivors even with peritoneal disease, who received chemotherapy and a proper debulking surgery. And then, of course, the GOG 131G2, second line gemcitabine docetaxel. So it's also approved for second line if you used adriamycin in the first line. And there was no additional benefit for bevacizumab to the gemcite and docetaxel. So you don't have any targeted agents here. And of course, doxorubicin is also approved for first and second line. And of course, you have a host of other drugs like gemcitabine, ifosfamide, trabectedin, eribulin, dacarbazine, the temozolomide and pazopanib, but due to shortage of time, I cannot tell you the individual response rates. The hormonal therapy, as was mentioned by the previous speaker, that there are some patients of leiomyosarcoma who could express the hormone receptor, so it could be used as a much later line of therapy if you have run out of the chemotherapeutic options. Coming to the important low-grade endometrial stromal sarcomas, you can see that in it would be advocated, and as was shown by the previous speaker as well, that adjuvant endocrine therapy would be advocated in stage 2 to stage 4. In fact, some would even give it in stage 1. And of course, the progestins are preferred because they do have because of the inhibition of the PR and anti-estrogenic effect on the endometrium, so reducing the proliferation. So the progestins are the first. What is the duration? Now 2 to 5 years depending on the stage, or indefinite if it is a stage 3 or stage 4 which is adequately debulked. As far as advanced disease is concerned, if you have a treatment naive patient, then it would be the progestins. And you can see you can even get CR rates of 17%, and aromatase inhibitors and GnRH analogs are the next group. Then SERM should not be used, and this is very important. Tamoxifen should never be used. The other uterine sarcomas are the high grade, and you can see that higher recurrence, however, no definite data on adjuvant therapy. In the metastatic setting, it would be the same drugs. Then you have the uterine sarcomas, which are like close to sex cord stromal tumors, no clear recommendations, low metastatic potential. There is some data which has been published on paclitaxel and carboplatin in this group, and of course the use of endocrine therapy. Then as far as adenosarcomas is concerned, it's unclear and treated like low-grade endometrial stromal tumors. Now coming to my last few slides, crystal gazing into the future of sarcomas. So any role for molecular diagnosis or somatic NGS? If you look at the leiomyosarcomas, you see a lot of chromosomal abnormalities, inactivating mutations, but no actionable mutation. And Dr. Eki has already told you what is the importance of chromosomal abnormalities in these sarcomas. And of course, the MSI instability and high TMB is uncommon. So there, you don't have much option of immunotherapy in these tumors. As far as somatic mutations are concerned, this is important because this was the latest publication in the JCO by Ingham that you do get 5 to 8% BRCA mutated with response to PARP inhibitors. And the response rate is 23% with the overall response rate of 27%, median PFS of 6.9 months. So this is an important avenue and one must try to look at the somatic mutations, and this is the study of the PARP inhibitors. And to conclude, I would like to say that gynecologic sarcomas are rare and heterogeneous. Early stage leiomyosarcomas are observed. Advanced stage completely resected and metastatic are treated with chemotherapy. Endocrine therapy is the mainstay of treatment of low-grade endometrial stromal sarcomas, whereas the high-grade and the undifferentiated should be treated like leiomyosarcomas. Insights into molecular alterations could lead to yield targeted therapies in future, and I think PARP inhibitors is one of the first ones to make their inroads into this part of the uterine sarcomas. Thank you.